Okay, so we're about 1 minute after the hour. Looks like we're reaching steady state on everybody joining, approaching about 50 on the line. Um, well, it's great to see everybody again. Um, my name is Keith Coker. I'm an emergency physician at University of Michigan. I'm also the medical director of the Michigan Emergency Department Improvement Collaborative, or MEDIC. And our organization, along with Michigan Department of Health and Human Services, have sponsored this learning series focused on ending the HIV epidemic, particularly with the tool of screening programs implemented in emergency departments. And so we've hosted a number of these webinars over the last 2 years. Um, Unfortunately, this is our wrap-up one, and we'll talk a little bit about where we are in the process and even looking to the future. But we thought we'd take the time today to talk about what we've done, the things we've learned, um, and potentially what we're going to do next. Um, so we'll hear from both the medic side, and then we'll hear from the Michigan Department of Human Services as well. So in addition to myself, you also hear from Kristen Swore-Wolf, who is emergency physician at Hurley and coordinates their local HIV screening program. Also part of our team has been Jake Mantuffel at Ford, who's also an emergency physician and directs their screening program. And of course, Sam Kesterson, who you also hear from today as well, who's been the program coordinator and the core, and probably the person you know the most, has been on all the emails that you've received. Um, Sam, can you go to the next slide? So let me talk a little bit about kind of the big picture, where we were, where we are. So the context here, of course, is this public health interest and really focused on ending the HIV epidemic. And we partnered with MDHHS through a grant mechanism to support implementation and advocacy of screening programs in emergency departments. And it really comes back to the fact that, because of medical literature and evidence basis that's developed over the years, the CDC really recommends that at some point in your life, individuals between the ages of 13 and 64 get screened for HIV. Now, usually that screening occurs in routine care, in primary care, but I think we all recognize that not everybody has access to routine care, that because of the way, our healthcare system is fragmented, that not everybody has a primary care provider, that some people may not receive care except in the emergency department. And so the emergency department can be a source of interaction with individuals who otherwise may not have a way to receive standard care. And is that an opportunity to deliver HIV screening to a population who otherwise would not be screened? And there's really an evidence basis around the feasibility and benefits of HIV opt-out screening programs in emergency departments. And because of that knowledge, we really partnered to implement these types of programs across the state. We really had like two arms of work here. Um, the one that we're in right now is a set of webinars that we described as learning series. And we'll talk through, some of the things that we did with that over the last 2 years. Another arm that you may not have been aware of is that we've been developing implementation support and connections with emergency departments around the state to advocate and implement these types of programs locally. And you'll hear a little bit about that as well. And as part of that work, we supported, with the help of MDHHS, some startup funds, what we call mini grants, to support some of that local implementation work. So Sam, I think I'm going to pass it over to you about this stuff.
Um, Hi, everybody. Again, Sam Kesterson, project coordinator here with the Medic team. So you guys have heard from me plenty over email, and I'm excited to be with you guys today. So, quick overview of some of the learning series stuff. We've covered a lot of topics over the last 2 years related to HIV screening, from everything from the public health side and the perspectives of the people that coordinate the care and connect patients to care, to surveillance, to epidemiology. We've heard from patients themselves who have, personal experience with HIV. We've heard from a few different programs that implement things screening differently. So the Focus program was one of those. We talked about stigma. We've talked even a little bit about syphilis, since that's been one of the goals of the state. And yeah, and now here we are with kind of wrapping up and talking about the things that we've done. And so, just a quick overview of how many people we've reached with this learning series. So, we have been able to contact over 660 individuals about this learning series and about these QI opportunities. And that's across 178 organizations. On average, attendance for each of these events has been 78, with the highest of 173 people at these learning series events. 14 speakers across 10 events. And as you know, we've been able to provide some CME credits. So that includes today. So I'll make sure to get you guys that information for claiming credits for today too. But I think that that's some pretty cool outreach, and casts a pretty wide net. On top of that wide net, I just want to show some of the diversity of the organizations and the people that have attended these. So it's been really cool to see people come together who are direct healthcare workers in the emergency department settings, in settings outside the emergency department, in the public health space at MDHHS, local health departments. So thank you guys for representing all of these different organizations as well as different roles. So it's really important to bring together a variety of different roles, as we know things don't exist in silos. And so getting people to work together so we can connect faces to names. When we talk about connecting someone to their local public health department, who really knows who that person is on the other side? And so by coming here and seeing each other's faces and names, that helps to build that bridge. So thank you guys for representing all of these different aspects during these calls. Some of the calls, we've also asked you guys to take some surveys. That has not been forgotten about. So we wanted to display some of the things that we can show. So we're definitely seeing that, folks are, by just coming here and participating in these conversations, we're seeing that people are identifying that the ED is a good space to provide this service, that it's something that people feel is needed. And we saw an increase in that. We've seen that there is an increase in people's perceived need for the general population to be screened for HIV. So, sometimes I've talked to like my friends and family or other colleagues about the work that we've been doing, and I hear like, oh, is HIV really a problem anymore? I feel like I don't really hear about that anymore. And I think that this is showing that, like, okay, yeah, this is still something that we should be thinking about in the healthcare world. So, and then this one is the one that I think is the most powerful from the ED perspective, is the HIV screening places undue burden on direct care staff. And the perception of that pretty significantly has shifted through our conversations here. Is it maybe a little bit of extra work here and there? Sure, but it's also needed. So it's not undue. And it's also not quite behemoth that it used to be. There's been some movement in policy, there's been some movement in technology and treatment and follow-up processes, all of that. So we are definitely seeing this shift. And so here's just another representation of the folks, how our attitudes and beliefs have shifted towards screening generally and in this emergency department setting. So um, that's it on the learning series. If anyone wanted to chime in about anything, feel free to use the chat or whatever throughout. This is really a celebration of all the things that we've accomplished and learned together. So um, happy to happy to open the conversation there. If not, we can move into recognizing some of our sites. As Keith mentioned, there's some of these QI opportunities that we talked about for implementing things around HIV screening and improving screening processes. So these are some of the sites that have engaged with us in various different ways over email, conversations, Zoom calls, site visits about HIV screening. So even just the simple act of learning what your organization does for HIV screening can help do things to improve its process. So it was really exciting to see some of that work and see some of the barriers and start to problem solve some of these things and have important conversations. And actually with that, we have Dr. Swar here, who is our clinical consultant for our HIV program, but during these last couple of years, they've had some exciting movement at their site for their HIV screening program. So, Kristen, I'll pass it over to you.
All right. Good afternoon, everyone. Thank you for the introduction. I'm Kristen Swar. I'm an emergency physician at Hurley Medical Center in Flint, Michigan, and also the clinical consultant for the physician consultant for the Medic EHE program. We have had an HIV screening program in place now for about 6 years. And for those of you who have been to prior lectures, learning series, you know that we have an automated process, semi-automated process that allows us to screen as many people as possible. During the duration of the EHE program with Medic, we have changed over our process and we have streamlined it. And I wanted to present this to everybody to show you, first of all, an alternate way to enact HIV screening in the emergency department. And also as an example of the fact that while this program is not burdensome, it is definitely dynamic. It can be streamlined and there's a couple different ways to do it. We like our new improvement, looking at our original process, and you can see we use Epic here, but likely we'll work with any EHR. Our original process was a two-step process that involved a nurse asking a screening question in triage and clicking a button and then moving the patient into the patient care area. When the patient was there, the provider, be it the PA or the physician, would then have to confirm after a pop-up was placed that the HIV order could be placed and then place the order. So then there were two steps, two people, and all of this was happening in two disparate places, both in time and in space. I can take the next slide. Our new process is nurse-driven and streamlined. However, it creates no extra work for our nursing staff. The original place where the HIV screening opt-out option occurred was in triage, and the process still remains in triage. But now, instead of having to wait for a physician or PA to confirm that the test is done, we've turned it into a one-click process. So the same questionnaire or similar questionnaire pops up asking or stating to patients at Hurley Medical Center, we routinely screen people who qualify for HIV. Please let us know if you don't want this test done. But now when the patient chooses to not opt out, the order is automatically generated as a standing order, similar to many like advanced triage orders that are already placed in our hospital. And then that order automatically comes up when nursing staff goes to print out any orders that have been placed for the patient once the patient is seen by a physician or a PA. The downstream process and the notification is unchanged, but we have had significant increase in our testing since that time. This is a chart, and it is a week-by-week chart from the end of May to mid-November. You can see we implemented this October 1st. For context, we see between 200 and 250 patients a day, and slightly less than half are either geriatric or pediatric and wouldn't qualify for our screening. So, that means that we have about, 150 to 180 eligible people who pass through our emergency department daily. Prior to this, or prior to implementing the screening, you can see that the numbers ranged from the 20s to 30s, and then they popped up to the 60s to the 90s to the 100s. And if you look at mid-October, that was also when I started attending some nursing 6 minutes, also known as nursing huddles, prior to the start of shifts, just to remind everybody that this program was in place to either educate or re-educate and to go through the process with them. I can take the next slide, which gives a summary. So our old two-step process, we were running about 180 screening tests each month, which averaged to about 6 people a day. Since this single-step process and since re-rolling out the program, we have had increased success. We had 448 screening tests in 1 month compared to 180 prior to that on average. And our daily October screening tests were nearly 15 a day. We only have the first half of November, but we're still holding steady at about 15 tests a day, which brings us to a good 15% of the 10 to 15% of the population that is targetable receiving the opt-out screening tests. And I think that is all I have. I would like to turn it over to Chris Arnold, our partner from the Michigan Department of Health and Human Services, unless anyone has any questions. All right, take it away, Chris. Thank you.
Thank you. Not a question, but it's really awesome to see that those changes that have happened in real time. So that's really awesome work with just those changes that you implemented in just the few months of time. So it's really awesome to see there.
Thank you.
My name is Chris Arnold. Thanks again for having me here. I'm the HIV and STI Prevention Section Manager in the Division of HIV Bureau of HIV and STI programs. And so I'll talk about, give a little background on EHE just to bring everybody back into the room on that, and then talk about some of the lessons learned. Oh, sorry, changed my view. There we go. So to kind of give a brief description of EHE, I think everybody on this call is, pretty familiar with EHE, but it's the 10-year Ending the HIV Epidemic Plan for America. The initiative was rolled out back in 2019 under the first Trump administration across like 48 counties, 7 states, including DC, Puerto Rico, and a couple of other locations. Overall goal is to reduce new HIV infections by 75% within the first 5 years, so by 2025, and then to reduce new HIV infections by 90% by 2030. And so these are the 4 pillars here on the screen. Diagnose HIV as early as possible, treat HIV quickly and effectively, protect people who are considered at risk through interventions like PrEP, syringe service programming, and other biomedical interventions, and then responding quickly to clusters or networks of new cases. And this project specifically focuses on those first 2 pillars, so diagnose and treating. And then getting into the next slide about how this project really kind of aligns overall with our strategic plan, at the state of Michigan. And so back in 2024, MDHHS, we went through the process and completed the Ending the HIV Together, Michigan's equitable plan, which again focuses on the 4 pillars that you just saw in the previous slides. And again, just for this project, focusing on the first 2 goals of that plan. And so the first goal being HIV testing, and I won't read, all of the points that are listed here, but really just wanting to focus on like that expanding access to HIV testing through a variety of mechanisms like rapid testing within the local health departments, our community-based organizations, and another focus with the ED testing. And then also focusing on that training of healthcare professionals on HIV and STI testing, and then falling in line with goal number 2 of the retention and care, so that treat pillar, reducing barriers to care and really destigmatizing patient care experiences and reducing medical mistrust. And so, why the focus on emergency departments, I think, has been a really big question for a lot of folks across the last couple of years. And so, the short version is that, our EDs really are often utilized as primary access points for care, whether it's primary care, routine health care, and the other, reasons that Keith had mentioned, earlier on. And so folks are coming in and they're presenting with a variety of different symptoms and illnesses, and a lot of them as they relate to the social determinants of health. And so, really, the EDs and a lot of times our urgent cares really, one screening in the emergency department can really open the door for someone to be diagnosed early and to receive the treatment that's necessary to get those folks virally suppressed. And so, really, it is just good public health. It's good for the patient and it's good for the communities in preventing the future spread and acquisition of HIV. And just a couple of additional notes that are not on the slide, but I can share those later. Right now, it's estimated that about 1 in 7 people are living with HIV and they don't know it. And so folks that are coming into those ED settings, those healthcare providers can really play a critical role in helping us reach those goals of ending the HIV epidemic, reducing, new HIV infections, reducing STIs, through timely screenings and testing and treatment. And then kind of as another side note, prior to 2020, our local health departments were actually the key access points for a lot of our HIV and STI testing across the state of Michigan. And so with that shift of COVID post-pandemic, that service delivery model has really shifted and it still is continuing to kind of trend upwards when it is coming to, folks returning to the local health departments and community-based organizations for testing. So the EDs have really taken on, a bit more of, that role of diagnosing new infections. And so kind of leading into the points that you see here, just that screening can really open the door to early diagnosis and treatment. It routinizes the standard of testing and provides that opportunity for patients who normally wouldn't seek out those HIV and STI testing opportunities at other locations. And so, like Dr. Spohr was saying, they have their protocol, it's posted. And so patients that are coming in can see like, oh, this is just a routine part of my care that I'm going to be receiving while I'm here in the ED. I'll be tested for HIV. I have the option to ask more questions or not take the test at all. And so along with that of routinizing that testing opportunity, it also reduces the stigma because there still is so much stigma surrounding HIV testing and all of that. And ultimately, it's relatively low cost for the emergency department. It does not cost a lot of money to make those changes in the electronic medical records, whether folks are doing like a BPA, an order set, or some other screening mechanism that they put in there. And so it's not a huge fiscal cost, but there is that time and effort and that goes into training providers, nurses, anybody that would be really interacting with the patient or with whatever that screening mechanism is in the EMR. So that's why the emergency departments. So getting into the lessons learned, first and foremost, it's okay to start small. Initially, when we took this project on a couple of years ago, presented it to the medic folks, I had these really big dreams and high hopes of like implementing best practice. I see Sam smiling right now of implementing best practice alerts, which is a very specific testing intervention in every EMR, in every ED across the state. And like I said, it was very, very big dreams. And as we continued to have those conversations with medic and our clinical champions, they were like, you got to slow it down a little bit. People will not like this. And here are the things that you're going to run into if that's the route that you decide to take. And so after more of those conversations, we really shifted the focus and changed the language because lo and behold, people do not like best practice alerts at all times and hard stops. And so while that is one avenue, it's not the only one to increase HIV screenings in the EDs. And so there are more inclusive strategies that would likely give more buy-in from, medical providers and other folks that would be interacting. And so I think the biggest lesson for me, and I think a lot of folks on my team, is that it's 100% okay to pivot. It's okay to start small. And really, it's about trusting the process and just being flexible in that approach. which leads into kind of these next couple of points here of making sure that you have the right folks in the room from the very beginning and that it truly does take a village. The number of folks that we have had that have come to the table has really expanded over the last 2 years. And so we've got subject matter experts on all sides, ranging from our clinical champions, so the medic folks, Dr. Swore, Dr. Mantuffel, they all have been really amazing throughout this process and have really helped us on the state side, who many of us are non-clinicians, to really speak that language. And also when working with ED providers, making sure that there are also those considerations to have all parties again, who would be interacting with patients or with the EMR itself. And then that kind of leads into the other components of, it was mentioned before, like nothing is operating in a silo. And so making sure that we've got those connections with our local health departments, our community-based organizations who truly have those deeper connections to community and can help to provide some of those additional resources of like helping with partner notification, linkage to care, and some of those other nuances that really take place after someone is newly diagnosed. And then from the MDHHS perspective, we have a really robust program, ranging from HIV prevention and care. We have disease intervention specialists, early intervention specialists, surveillance, epi, evaluation, and a lot of other folks who work behind the scenes. And it's really, really important to have, those perspectives, as they've all been really important to the process. And it's been said multiple times on this call, just the relationships, they matter. And public and private sector, and really trying to kind of work on those relationships. I think that's something that has improved, at least in my tenure with MDHHS, because we're all really working towards the same goals of making sure individuals are healthy, making sure we have healthy communities, and really how can we work together to really meet those goals. And this project has been like a true testament to a lot of that. And then again, just really wanting to encourage folks to get to know your folks on the local level, get to know your folks at the community-based organization level, because again, they have those deeper connections with community. So that kind of gets into the future and sustainability. The algorithms, they don't go away. They really just get more refined with time. Dr. Swore just shared, like they had one model, they shifted to, the nursing triage and have seen all sorts of, really great improvement and things like that. So the process just gets more refined over time. And then we've received the Rural Health Transformation Grant, and for folks who are not familiar, it's part of the One Big Beautiful Bill. It's like a $50 billion grant that's come out from the federal level. I think all the states are getting roughly $10 billion, and so they each have had, opportunity to put forth proposals to talk about, how we are going to make improvements in rural communities. And so a proposal was submitted for the EHE Collaborative to do some expansion. So taking this model, but really kind of honing it in a little bit more and focusing specifically on rural Michigan, which I think everybody knows that Michigan is mostly rural. There's like 75 counties that are considered rural by census data and all of that. And so it won't just be HIV focused, just because, again, there are a few more nuances with rural communities. So it'll have a focus on HIV, syphilis, and hepatitis C. And so as we find out more information, we're still waiting for kind of the final details, but again, we'll be partnering with Medic and a couple of other organizations and internal staff to really kind of, do the same model, but for rural communities. And then the last thing is really just continuing to build and foster those relationships between public and private sectors, because that's how we can get the work done together. And that's it for me, unless there are any questions.
Yeah, we can certainly pause for questions.
I was just curious why the information series is stopping.
For right now, the funding that we have to support this project, it ends in April. And so with the Rural Health Transformation Grant, I imagine that there could potentially be more learning series and learning opportunities. So that's the reason why it's stopping right now. But hopefully there'll be more to come in the future. because they have been great.
Yeah,
And
when I first got into my position as an expanded testing program coordinator, started coming to these. And so I guess just it's interesting to kind of see things come full circle. I now have 9 fully executed contracts, and I'm doing the ET work through Rapid, so it's a little different. But yeah, so I've taken a lot of the things that Kristen has said and tried to implement them and use them to, let's be honest, persuade, administrations at healthcare entities and the 37 county region that I serve. So yeah, it has been very beneficial. So thank you for all of your hard work.
that's so good to hear. And we're not going away. You can reach out to any of us if you have interesting topics or topics you think would be relevant for future either learning series or outreach. We would love to hear about them, even if we don't have anything scheduled yet. Congratulations on your progress.
Yeah, thank you for your comment, Caitlin, and it's great to hear that folks like you have found value, in the learning series. And I think it remains to be seen kind of how this may morph into another set of webinars. It just remains to be seen a little bit what that looks like.
We have a question in the chat from Crystal about the involvement with McLaren, specifically Lansing and Central, considering the student population. We haven't had a ton of like in terms of like QI calls specifically, like we had mentioned before, or a lot of back and forth there. But again, certainly I know Isabella County is a rural community. I believe it's still classified as that with the state. So yeah, so hopefully, moving forward, we can definitely consider those keeping those conversations moving. So Crystal, if you wanted to reach out to me, I'll put my email in the chat. I'm more than happy to continue talking. I love that, Caitlin. I love that we like expanded across the country. It's amazing. All right. All right, I will share my screen again for Keith. So we still have a few exciting things coming up. So
Yeah, so let me kind of wrap up a little bit more with some additional yeah, kind of output that we're going to have related to this program, and I'll also give my thoughts similar to Chris about what I see as the future. So one of the things that we're currently working on and have been working on, largely pushing forward because of Sam's efforts, is what we call an implementation guide. So this will be a document that will summarize kind of all the things that we've learned and sort of drawn on kind of all the things in particular that we've talked about and learned in the learning series, and what we've learned on the ground and with other experts around how to do the actual implementation work for HIV screening within the emergency department setting. That is a whole host of considerations, not just kind of what motivates the work, but how do you actually operationalize implementation? For those that work in the ED, it's not, to be honest, like a simple task of just do it. You have to think about, job families and workflows, and there are different choices, all of which could be totally valid, but require some customization to your local context. There are things like, what does the public health code tell you, and how do you ensure that hospital administrators sort of understand and sign off on these type of programs. There's also solving, the linkage to care, and there are barriers around that. And that's where, having, local public health department support can be so valuable and meaningful, and how do you sort of make those connections like Chris was talking about. So basically, it's going to be a how-to guide that ideally you can pick up and help you think through how you might go about implementing these kind of programs. It's in development, as I was saying. We hope to have it completed in the next couple of months, with the plan to then disseminate this, certainly through this forum and network, but also I'm sure through MDHHS. Certainly we'll post it on our website, as really something that hopefully is going to add value and help you, do your work as well. And then Sam already mentioned this, but we've been recording all these learning series along the way. We host those recordings off the Medic website. They're freely available. You can watch them, download them anytime you want. We also have several other materials like on that website related to HIV screening in emergency departments. This is also where we'll host that dissemination guide when we get, or the implementation guide when we get there. So I'm glad you felt it valuable, and we hope that it's like a resource that will forever be there as well. And then, there is a future, we think. Chris was already describing some funding coming online to the state, perhaps, more of a focus in rural communities. We think this means that we will continue with the work that we're already engaged in. It may look a little bit different, but I think as it relates to all of you, we think that you have been such an awesome, engaged community, and want to be sure that we continue to keep you in the loop. And so you may see from us again, emails, requests, connections, and maybe even some future webinars to be determined, as we sort out like what the next version of this looks like. And I see all these like hearts and thumbs up, and that certainly warms my heart. And I'm glad people felt like this was a value contribution to all of your work. So thank you. Let me start pause there and see if there are any other sort of questions or comments, from the group, before we kind of wrap up at the end.
Also going to leave this screen up too so people can see the CME credits. I also just posted it in the chat as well. So I'll just leave that up as we talk.
Thanks, Sam. Yeah, as a reminder, we get our CME accreditation through University of Michigan, and so they require that you claim CME if that's something you want within 7 days. So just remember that if you want it, you have to claim it within 1 week. All right. Well, I appreciate that final comment from you, Caitlin, and certainly all the nice things people have been saying along the way in the chat. And I guess we're going to sign off for now, but not necessarily forever. So it was so great to engage with all of you as a community, and we look forward to continuing the work, as we sort out what that looks like. Chris, you've been an awesome partner, and I know we'll continue working together. So maybe I'll just say thank you, but we'll see you again.